1 minute. Thank you for logging on to today's webinar. It's time to close the gap, implementing substance use screening and brief interventions for adolescents in mental health settings. We're going to be beginning momentarily. Thank you for joining us today. I'd like to welcome you all to today's webinar. It's time to close the gap, implementing substance use screening and brief interventions for adolescents in mental health settings. At this time, I'd like to go over some housekeeping items for today's webinar. We'd like to encourage you all to participate in today's webinar via 2 methods. First, if you have questions for today's speakers or are experiencing any technical issues, please use either the chat box or the questions pane to communicate your questions. Periodically throughout the presentation, as well as at the end of the presentation, we're going to stop and ask for questions, at which time I'll read aloud any questions that have been submitted. Again, you can submit questions via the comment or questions box. We will not be using the raise your hand feature on today's webinar, so please direct all your questions to the question or chat box. You're also able to collapse and expand the GoToWebinar panel via the arrow button should you choose. Now, following today's webinar, you'll receive evaluation and continuing education request information. This webinar is approved for 1.5 PA CADC or 1.5 NADAC credits. You can also request a general certificate of attendance. I'll go over how to request these CEUs as well as access them at the end of the webinar. Now, at this time, I'd like to go through some poll questions. Our first question is, what is your current professional role? Are you a counselor, therapist, social worker, or case manager, a nurse, nurse practitioner, physician, or physician assistant, a program or unit administrator, a university student or faculty, or other? And if you select other, feel free to share with us your profession in the questions box or the chat box. Okay, great. Thank you for everyone who participated. I'm going to go ahead and share those results. Looks like the majority of our audience at 50% is either a counselor, therapist, social worker, or case manager. I do have some other answers coming into the questions box here. We have a project manager as well as a healthcare advocate. For our second question, which field do you represent? Do you work in mental health, addictions, physical health, education, or EAP? And if none of those apply to you, again, feel free to send us the field you work in the questions box or the chat box. Okay, great. I want to thank everyone for participating in that poll. I'm going to share those results as well. Looks like the majority of our audience works in mental health or addictions. And for our third question, do you currently conduct SBIRT interventions? Okay, great. I want to thank everyone again for participating in that poll. And it looks like the majority of our audience at 62% does not currently conduct SBIRT interventions. And for our final question, do you see your agency using SBIRT? Okay, great. I want to thank everyone again for participating in that poll. And for our final results, 81% of our audience selected yes. I'd like to share a couple other answers that have come into the questions box here. Someone works for a drug-free communities grant. We have a psychologist. Someone looking to put SBIRT into their practice. They also recommend, another person recommends using it with others, and another person wants to introduce SBIRT to schools. Now at this time, I'd like to introduce our speakers for today. Mr. Aaron Williams serves as the Director of Training and Technical Assistance for Substance Abuse for the SAMHSA Center for Integrated Health Solutions at the National Council for Behavioral Health. In this role, Mr. Williams leads the National Council strategic initiatives on substance use screening and treatment and provides direct training and technical assistance to promote primary and behavioral healthcare integration with special attention to addiction treatment providers. Mr. Aaron Surma serves as the SAMHSA Center for Integrated Health Solutions Senior Evaluation Associate at the National Council for Behavioral Health, regularly working with mental health and addiction providers organizations to make better use of the data they already collect. He stresses the meaningful use of data on the consumer, clinic, and administrative level, with an emphasis on continuous quality improvement. Mr. Surma has earned 2 master's degrees, a Master's of Social Work from the University of Michigan and a Master's of Accounting from the Eastern Michigan University. Now at this time, I'd like to turn things over to our speakers for today. Mr. Surma and Mr. Williams, if you're ready to go, I can make you the presenter.
Okay.
And I have unmuted both of you.
All right. Okay, so thank you. And thank you for having us here today to talk about this important topic. Today, what we're really going to do is talk about a project that myself and Aaron Surma have been a part of for about the last 2 years. It's a project to begin implementing screening and brief intervention as well as referral to treatment services for substance use into primarily mental health settings for adolescents. So we'll talk a little bit here today just to give you sort of an overview of what we're going to talk about. We're going to talk a little bit about the project, sort of what it is, and kind of give you an overview of the project. Talk a little bit about the data and why this project was necessary. Then, get into sort of what we do through the project, what sort of technical assistance and support we are providing to agencies that are participating in the project. And then we'll have a longer discussion about, what have been the results so far, related to the project. And as well, at the end, we'll talk a lot more about some of the considerations in each of the sort of steps of the project. So that's what we want to cover today, to really give you insight into, how this project has gone, sort of what we think the large implications are for agencies who are interested in doing this or implementing these services, and then have some time at the end for questions from a number of you about, nuts and bolts or other things related to the project. Okay. So the first thing I want to start with is, to talk about, the project generally. Essentially, we were, started a 2-year project with a number of providers across the country, primarily mental health providers serving adolescents, and they were beginning to implement substance use screening, brief intervention, and referral services for the adolescents there. So the first thing I want to talk about is sort of, what is the impetus for this project? Why was this project funded? What were the thoughts kind of behind, thinking about this as a technical assistance opportunity for providers? Well, there's a lot of work out there now, a lot of research that's been done that talks about the correlation between adolescent substance use and mental illness. So here we have a little bit of the data that's kind of out there, just talking in general about the number of adolescents. About 1.4% of adolescents aged 12 to 17 had both a substance use disorder and MDE, that's a major depressive episode. So you're just thinking about just the correlation between substance use and major depression. Adolescents with mental health problems often see a lot of increased substance use, alcohol, marijuana, other drugs. Youth aged 12 to 17 with a major depressive episode were much more likely to have a co-occurring substance use disorder than folks who didn't. And the number one predictor of adult substance abuse or dependence is use of substances and substance use problems as youth. So if we think about all of the things that are going on in the larger landscape around adolescent substance use, around preventing long-term substance use, you really want to take a look at and address the substance use that's happening while they're in the youth, teen, or adolescent ages. And if you want to address that, you begin sort of delving into the correlation between this and mental health disorders. So part of the rationale for the project was really looking at this correlation and understanding that folks who are coming into agencies for mental health disorders may also be at significant risk for beginning the use of substances, which can lead to long-term substance use and disparate health outcomes in the future. So just another one of these studies. In 2013, there was a pretty large study, a longitudinal study that looked at teens with bipolar disorder, and basically what they found was that teens with bipolar disorder were 4 times as likely to develop a substance use disorder when they came back for a 4-year follow-up. So again, folks, teens with substance use disorders, teens with mental health disorders, being much more likely to begin developing substance use disorders if those things aren't addressed early on. As a part of this study, they looked at some of the factors that predicted later substance use, so substance use later on in life, so further down the road, and any diagnosis of oppositional defiant disorder, panic disorder, family history of substance use, low family cohesiveness, absence of antidepressant treatment. So if you think about those factors, a lot of those factors are very clearly there in a number of the clients, adolescent clients that come in receiving mental health services, whether they are coming in as a referral from a school-based counseling center, or parents bringing them in on their own, or a health center or some other entity is referring them for further mental health services. These are clients that are very clearly at risk for beginning to engage in substance use and having substance use problems later on in life. So this is just some data here, from the Monitoring the Futures project in 2014, looking at the use of substances generally across the country, giving you a sense of kind of the drugs that are being used. 8th graders on the left-hand side there, and 12th graders on the right. Thinking about the use of marijuana, we have, clearly looking at the larger landscape with the movement towards legalization, decriminalization of marijuana. thinking about, ideas and other things related to adolescents and how they view marijuana in terms of the health consequences or the safety of marijuana. The further on we move towards this idea of, legalization or decriminalization, there's studies that suggest that adolescents view marijuana as being much, much safer. On the flip side of that, there are also lots of studies now indicating that marijuana that's coming in, that's being utilized, is far purer, much higher in concentration of THC in the marijuana now. So you have, people viewing marijuana as increasingly safer, yet the purity of the marijuana being used is going up, potentially causing lots of problems there. On this slide, what's not on this slide is actually use of alcohol, which is still sort of an ongoing problem, in adolescents, particularly, teens and folks at the early college stage, so binge drinking and the like. So let's talk a little bit about the project and sort of, what it is and kind of, how it sort of works and is organized. The Reducing Adolescent Substance Use Initiative, or RASI as we call it, is funded by the Conrad Hilton Foundation. So the Conrad Hilton Foundation really has a mandate, around this idea of protecting vulnerable populations. And one of those populations of interest is youth and adolescents, particularly around substance use. So looking at early intervention, prevention, and other initiatives related to protecting adolescents from long-term consequences of substance use is something that is a particular priority for them. So they've been funding a number of projects, this being one of them, related to those sort of implementation, early intervention sorts of activities. And again, given the correlation between mental illness or folks coming in with sort of conduct disorders and the like, this was probably a good opportunity for them to really look at how can we, continually, engage youth at a much earlier rate, age, and move them forward in a way that makes sense and will lead to lower risk around substance use. So again, the project is really sort of focused on substance use, again, prevention, early intervention, protocols, use of screening, so brief intervention, referral to treatment process. So really thinking about mental health organizations and, if they have any formal screening process around substance use, working with them to implement a screening process around substance use, and then looking at sort of what sort of services will need to come later, if necessary, brief interventions, and potentially referral to treatment if someone needs a higher level of care, whether that's internally, externally, or thinking about sort of co-occurring disorders treatment, but really looking at helping these organizations begin building infrastructure to really serve the youth in a much more holistic way, particularly around making sure that they are asking questions and providing services for substance use. So really what we set up was a 2-year learning community, which is focused on sort of a structured learning process. We have a number of webinars, face-to-face meetings, other coaching calls, technical assistance with the organizations, which I'll talk a little bit about here in a second, and really providing a lot of support to them, as well as a part of the project, working with the states to really talk with them about, what the infrastructure is within the states to begin supporting these kinds of, activities and practices. So again, work with state associations on policy changes, really helping them think about, how they can enhance the sustainability of providing these services within these settings. So we got a lot of feedback about that part of the project as well, which we'll talk about a little bit later. Okay, this is just a map and sort of a quick overview here of the participating organizations. So you see we have about 6 states, California, Colorado, Kansas, Tennessee, New York, and Rhode Island are the states that are participating in the project. We had a number of organizations from each state. So I believe in total we ended up with about 27 agencies that ended up participating fully in the project, from those 6 states. And also as a part of this, again, we had the state associations there, again, to help facilitate working with these organizations and also looking at any sort of policy initiatives at the state level that may need to be changed or any sort of advocacy work that needed to happen at that level to ensure overall sustainability of these particular services. So what kind of activities have we been engaged in over the last 2 years? Essentially, we've had a number of in-person meetings, a number of webinars where we talk with the project leads, these are the organizations, to discuss sort of how things are going, what do they need to do to begin implementing these kinds of services. We're doing a lot of work with clinicians, helping them, get up to speed in terms of use of the screening tools, and conducting brief interventions, or having sort of focused parts of their sort of routine treatment interventions that are focused on substance use, helping them work through that. Lots of training and coaching calls with them, talking about such things as motivational interviewing, really helping them to kind of, look at how they can help adolescents sort of move through this process in terms of providing interventions and services they need, again, to intervene early around some substance use-related issues. Data jams, so all of the organizations, had to submit information, again, which we'll talk about a little bit later. They had to submit information about the numbers of screens, brief interventions, referrals, those things that they have been doing. And, we, really think that, using the data is paramount and, helping organizations in terms of quality improvement. So we would actually have webinars where we would basically push the data back out to these organizations to let them know, what this looks like across their state or, across the actual, learning community. So they can see how many folks have been screened, what kind of brief interventions are happening, referrals and the like. We really wanted organizations to look at the data, see where they were with the project, and then, we can work with them about how to improve or enhance the service delivery model. About middle of the year, we talked to the CEOs of other organizations. Really, this was a check-in. We're part of this, project. In order to make these projects work, you really want to have, executive administration buy-in. This is for a number of the organizations. They weren't doing a whole lot of substance use-related screening, so this was really sort of a sea change for them to begin thinking about this, in this way. So we really want to, make sure that we move forward and have meetings with them about what's happening and making sure that they're invested in buying into the process. We have calls that we have with each of the states, state associations, where we talk with them about, what's happening at a, state level in terms of, issues like billing, other sort of sustainability issues, and how, they can move forward to enhance, that aspect of the project in terms of policy changes and the like. So then we also had some all-site calls, that were, there for organizations to talk and really dialogue back and forth. As I said, this is more of a learning community process, so we really wanted to have some time where organizations got together and could really talk back and forth about how things are going, ask questions of each other. Really part of that learning community process is based on this idea that, the peers, really have a lot of insight and interest in the project, and they can be helpful to each other, in this sort of shared dialogue and shared process. And then a few other, learning activities we have. Again, there's other sort of updates, newsletters, other webinars around other relevant sorts of, data, things that they ask for, that come up, during the project, whether it's, webinars specifically about use of marijuana or other things. We've been providing those services as well. Sorry. So I'll stop there and then we'll talk a little bit here about sort of how things have gone as the project has moved forward. So now I'll stop and turn it over to my colleague here, Aaron Surma.
Thanks, Aaron. And thanks to Irina and ATTC for having us. This is really exciting now that we are far enough along in the project that we can share what's going on to date with you all and hopefully spark some interest in this and get you all moving, those of you who are at least leaning towards doing SBIRT, moving in that direction. So we're evaluating this project. The purpose of evaluation in all circumstances is how do you know you're doing a good job? So in this particular instance, we basically want to look at, did organizations screen, did they briefly intervene, and did they refer to treatment when appropriate? And then was it effective? That's the framework of what we're looking at. And Aaron, if you want to go to the next slide, please. And it's kind of a balancing act. Of course, we want to collect piles and piles of information and do very rigorous analysis, but that's not realistic. We're not providing grant funding to the organizations doing this work. So the idea is to collect the bare minimum necessary for us to provide feedback around fidelity to the SBIRT model and to kind of get folks moving in a direction of collecting their own data to use for continuous quality improvement on site. And Aaron, if you can just tap it one more time, I think there's a couple of text boxes that show up. Yeah, so the two columns here could be worse, could be better. So the state associations are using the data that we are collecting to promote SBIRT legislation. That's one of, I think, the key pieces of this project is not only are we working with the providers, but like Aaron said, we are also working with the state to eliminate policy barriers to doing this work. The data we're collecting also supports post-outside quality improvement. So the idea is that we are taking patient-level data, sending it back to the organization, and giving them a dashboard that we think would be helpful with the hopes that they will use that as kind of a jumping off point for when they continue doing this work after RAZA. And it's also used for us to identify areas of need. So we can look at the information that we have available to us and say, oh yeah, organizations aren't grasping this point or struggling with this in some way, so we need to focus our energy as a technical assistance provider in these certain areas. And of course it could be better. It would be great if you're able to do some kind of cost analysis to sell this to the states and say, hey, look at, you spend $10 on doing SBIRT activities and you save $50 down the road. That's always the kind of gold standard of any project like this, if you're able to talk about the cost benefits. We'd like to have a more strict model, more strictly defined what SBIRT is. We'd like more consistent outcome measurement and more detail about the referrals and interventions that folks are doing. But like I said, we're not giving anybody grant money. Hard to ask for too much rigor in the data collection, and everyone who's participating is already being very generous with the amount of data that they're providing back to us. And so that's our balancing act. We're taking what we can get. Next slide, please. So this is the information that we are collecting on every person screened under this program. This is what the clinician's filling out. So the clinician's sitting down with an individual. It's the organization's doing this at intake. It's the very first time the person's come in. Some organizations, they do intake, and then this is the first time with the clinician. There are also some organizations that are screening with existing clients because they just started implementing SBIRT, but they already had these existing folks. So this form right here in front of you is filled out by the clinician after the individual has filled out either the CRAFT or the UNCODE. There's two screening tools we're using. Both ask about alcohol use, drug use, and risk behaviors associated with that use. And in addition to those scores, which you see those on the bottom here, we're asking about general information, gender identity, ethnicity, race, smoking status, and diagnosis code or behavioral health diagnosis. And we'll get to how we're using that stuff in a minute. So this is kind of the general, these are the facts. This individual's name is this, their age is this, their score is this, their smoking status is this. And then if we go to the next slide, you see the rest of the patient-level data collection form, which shows the clinician's actions and behaviors as a result of the screen. So that first question here, score warrants brief intervention or referral to treatment, we're measuring whether or not the clinician is interpreting the screen to mean what the developer of the screen intended. So if an unscoped score, and it's not coming up with off the top of my head, I think it's like a 3 or up, normally means brief intervention. Did the clinician check yes here and appropriately acknowledge that the score warrants a brief intervention or referral to treatment, or did they say no? Which we would interpret as the clinician didn't properly interpret the screening score. And then the second question here gives leeway for the clinician to use their professional judgment to override that score. So it allows the clinician to acknowledge that, yes, the score typically would require a brief intervention or referral to treatment, but I have a lot of other information about this individual above and beyond the one screening score that we collected, and I've used my professional judgment to do something other than what the screening guidance suggests. So we want to, the whole purpose of these two is to measure the fidelity to the scoring rubric of the screen. Did the clinician look at the score and react in the way the scoring guide suggests? If they did not, was it because they decided that, based on other information, something else was appropriate? And then we get into the date of brief interventions. We went to 4. And this is so that we can determine when are brief interventions happening. Are they happening right at the screening date, or are they happening later? How many are happening? And the limitation here is that we don't know exactly what happened at the brief intervention. So that's something that we talk about during the coaching calls. We have webinars about this topic, but we're not getting any feedback from the providers about what they're actually doing at the brief intervention at the consumer level on this form. So we can have conversations, we talk about it, we educate about what a brief intervention is and can include, but we are not getting that feedback in this format. So we're getting the date of these brief interventions, if they did occur, and after that we look at whether or not the patient was referred to treatment, did they attend treatment, and that's the other piece, the brief intervention, did they happen, then the referral, did it happen? If it didn't, we have the refused option because we want to differentiate between no, the person didn't go because it wasn't available, or no, the person didn't go because they declined that treatment. And the reason we want to do that, differentiate between those two, and I think we could have laid it out better, well, it's unclear on this. That's one of my many regrets in this whole process. So we want to differentiate between the two because the actions taken by the provider are different depending on why the individual didn't attend treatment. If everyone's refusing, then it's a motivational interviewing situation. If everyone is not going because they're unable to, then you don't have access, there's not enough access to treatment in your area, and that is a whole different fix. That's what we're trying to differentiate there, and you'll see some of the results of that later. And then the final piece, and probably the most compelling piece, is follow-up scores. So for everyone who is at risk at baseline, and risk is defined by the screening tool, by the developer of the screening tool, did the person get better at follow-up? And we asked for 3-month follow-up, but if the organization has a canned approach to engaging with individuals, if they normally see people for 6 weeks and then discharge, normally see them for 6 months and then discharge, we gave leeway. I said, all right, 3 months is our standard, but if you have a different standard that you're already using, do the follow-up at that point and rescreen so that we can see whether or not the individual improved. And that's what this whole thing's about. Does screening, brief intervention, referral to treatment actually lead to reduced risk activities and substance use? That's kind of the silver tuna, if I can quote Home Alone, of this whole thing. Could we go next one, please? That's all the information that's coming in, and this is the information that we send back to the organization. We have this for all providers who are participating. We have this by state, and then we have it by individual organization. And if there's anyone on the line who is a part of our initiative, I just got this last night, so you all will get it shortly. And this is a little sneak peek for you. Hopefully it's not frustrating because I know it's late and I apologize horribly. But this is what we're sending back to folks. So the first sheet is descriptives of demographics mostly, age, race, ethnicity, behavioral health diagnosis, smoking status. So again, these are just the facts about the individual and don't relate to the actual SBIRT process. So where this information is helpful is if you want to look into the factors that affect a person's success in improving at their follow-up screen, or if you want to look at the factors that associate with somebody who did attend treatment versus someone who was referred and did not attend treatment, that's where this information comes into play. Is it more likely for 15-year-olds to improve than 22-year-olds? Is it more likely for men to improve than women? Is it more likely for people with disorders to improve than people with learning disorder? You can parse out your population by all of these demographic categories. And can you go next slide, please? So here we get into the fidelity to the model. And this is graphical representation of the fields that we were looking at in that data collection form that was on the previous couple slides. So the first chart here in the top left, this is a summary of all of the CREST and UNCOPE scores. And if you saw on the top of the last slide, it was around 2,000 people have been screened through December 31st, 2015. And of those 2,000 people that were screened, 50% didn't require an intervention whatsoever. And 43% required either brief intervention or brief intervention and referral to treatment. 5% didn't have a missing score at all. So what you do with this information, it gives you a general idea of your population. The missing score piece gives us information. You go back to the providers and say, hey, this is missing. This is a piece of your data collection process that is worth paying attention to, because if you don't have the initial score, it is hard to drive the rest of the process, and you will not be able to track whether or not the person improved over time if you don't have that baseline score. So it helps promote fidelity to the model. It also is just food for thought. How many of the people that we are seeing have these issues? Then we get into the top right. Did the clinician classify the individual based on the scoring guidance of the UNCOPE or CRAFT or not? And middle left, the clinician's next steps. And so I think this is the next key piece. This is the driver of the three charts that come after it. There were 78% of the people were brief intervention or referral to treatment were pursued, 22% that weren't. So now we're looking at these 662 people, the 78%, where the clinician said, yeah, we need to do a brief intervention or referral to treatment or both for this individual. And that is the population that we want to track and see whether or not they received the brief interventions and referrals to treatment, and did they improve over time. If we bounce down now to the bottom left, there you see the number of brief interventions received for that 662. Actually, it's a little bit more than 662. I don't remember exactly how that adds up, but this is the number of brief interventions received. Excuse me, that's out. Never mind. I'm getting ahead of myself here. The point is, these are the number of brief interventions received for individuals who were shown to be at risk. So 30% don't get any brief intervention, even though they're shown to be at risk. 51% received one brief intervention, 12% two, 3% three. And the immediate question is it really true that 30% of the people who need a brief intervention did not receive one? If that is true, then you have to question why not. If it's not true, then we say, all right, where did the data collection process break down? And this is the kind of thought exercise that we hope that all organizations are using as they're looking at these dashboards, so that they can create their own data collection and review process once this initiative is done. So at the very least, you hope that people are receiving brief interventions when they're supposed to. You have this number in front of you, and you ask whoever is in the room who's involved with this process, is this number correct? Is it really correct that 30% of people who should have a brief intervention do not receive one? If it is, then how do we fix it? If it is not correct, what do we do so that we can rely on this number so that we can use it going forward to better inform the care that we are providing to the people we see. In the bottom right, it is similar for the people who their score warranted a referral. Did they receive a referral or did they not? 25% did receive a referral, 75% did not. And you can parse that apart, and there's a lot of different answers. When we've had this conversation with providers, a lot of them don't have a solid referral destination. So that's a big chunk of that 75% is they're just no one to refer. We also didn't do a great job of defining referral. So part of it's on us. We didn't define it properly from the get-go, so now we are doing that midway through. And I think Aaron's going to get into that more later, so I won't get too much into it. But that's where terminology and setting standards and defining the model from the get-go is important. If you're looking at whether or not referrals happen, everyone should have the same idea of what a referral is. We didn't create that shared understanding of a referral when we started this whole thing. Next slide, please. And here we get into outcomes. This is the good stuff. This is what I think most folks care about the most. Did people improve? You see in the top left that 41% showed any improvement from baseline to their follow-up. 21% improved so much that they are no longer at risk. So everyone in that 20% is also included in that 41. They're not mutually exclusive. So we can say that of the 123 people who were at risk at baseline who also received the follow-up, 41% showed any improvement, 20% no longer at risk. That's great. It immediately begs the question, how do we get more follow-ups done? And that's going to be a focus of our training and technical assistance going forward. And that's always a tricky one for folks. It's really easy to do all this work the first time you sit down with an individual, you do the screen, you talk to them about the screen, they're newly engaged in treatment, so there's kind of a routine. But if you're not used to rescreening, then it's not just a simple SBIRT issue of, well, we just need to do that uncope and that prep screen again. It is more of a agency culture or agency policy and protocol situation where rescreens aren't the norm in general, and that's a whole different conversation. And these are all things that I clearly enjoy talking about. That's why I'm running at the mouth right now. And I have lots of thoughts about it, so please feel free to follow up with me about any of these topics that we're talking about right now, because I like to talk about them. So the rescreens, big deal. That's how you know if people are getting better. Right now we have 123 rescreens for the close to 1,000 people who were at risk. So all we can really speak to is this 123. We have this whole black hole of information for the other 800 and however many who didn't have a rescreen. And so I'd also ask the questions, are the people who rescreened the people who were more likely to show improvement, and they stuck around, that's why they didn't rescreen? And we don't know. We don't know what happened to the folks who didn't have the rescreen. That's why developing workflows for that rescreen is so crucial, because that's the only way you can answer the original question, which is, I paid attention to that SBIRT webinar. Our organization has invested in doing SBIRT. Do we know that folks are actually getting better? So that's the whole thing. Top right, we have treatment attendance. That's a biggie for all the reasons I mentioned earlier. Some folks refuse, some folks don't have access, some folks have a different definition of what treatment is. The attendance numbers look different. And then the timing of the referral to treatment is in the bottom left. So when did the referral happen? Was it right when the screen happened? Was it after a couple brief interventions? And this is, I think there's a lot of different ways to use this piece of information. I like to use this as a starting point for a conversation with clinicians. What's most normal for you? When do you find a referral to be appropriate for an individual? Is it, oh my goodness, the score is so high that you clearly need a referral right off the bat? Or do you approach it with, I'll have a couple conversations with the individual, and if the brief interventions appear to be effective for the individual, then we won't go to the more intensive and expensive and potentially cumbersome full treatments. And so we'll stick to brief interventions. It's a good opportunity to have these conversations with the clinician. So that's why we have the timing of referral receipt here. And then bottom right, number of days elapsed between referral and treatment. The average number of days is 34, and that graph, the arrow's in the wrong place. And this is just what happens when you get the charts the night before a webinar. Some of it's a little bit ugly. So that one will change, but that number is correct. The average number of days between referral and treatment attendance is 34, and that's a huge gap. We identify on January 1st that an individual needs treatment. They don't actually show up to treatment until February 7th or 8th. What happened in the interim? Are they still engaged in some kind of interactions at the original screening site? Are they not talking or seeing anybody because they were only referred without any kind of brief intervention still provided in the interim? It's a big gap, and it's interesting to look at the follow-up score to see whether people improve when the number of days between referral and treatment attendance is shorter. And we see that in a lot of other settings, particularly in integrated health settings where Aaron and I spend most of our time, which is that the shorter that gap to in any kind of referral increases the likelihood that an individual will attend the particular appointment, which then is the intervention that leads to better outcomes. So closing that gap, significant, helpful, and something that we always work on. This is the data that we're spitting back to folks. Hopefully they're making use of it. Some are. And more poignantly, we hope that they are using this as a way of developing their own thinking around what's important to them to track once the initiative's completed. Aaron, next slide, please and thank you. And the next slide, I believe, if I remember correctly. Okay, so this is one last thing I want to talk about. We did a couple different classification trees to look at the predictors that lead to different results. And the one I'm showing you here is the different predictors that lead to people improving from their baseline screen to their follow-up screen. And what you see on the left column, you can ignore the stuff in the middle on the right. What you see in the left column is the different variables that we looked at to see what drives positive outcomes. And we only have 99 outcomes that fit the criteria for this. Not nearly enough to draw gigantic conclusions. And we also don't have great fidelity of the model. I think there's still work to be done in cleaning up the data collection process at each site. So take this with a gigantic grain of salt. I think the important lesson here is that it is possible for everyone to do this kind of analysis. So take a look at those predictors on the left side and just think to yourself, what do you think were the greatest drivers of an individual improving from baseline to follow-up on their screen? We have whether or not they received a brief intervention, whether or not they received treatment referral, what organization they were at. So we're looking at this from zoomed out look at 27 organizations. We have gender, race, whether or not the individual is of Hispanic ethnicity, age, and whether they have any behavioral health diagnosis. So basically what this is asking is an individual's gender more important than their age? Is the fact that they received a referral, the treatment referral, more important than the site they're at? Is the fact that they have a behavioral health diagnosis more important than their race? And Aaron, if you want to skip to the next one, these are the results of that analysis. So when we looked at it, and when I say we, I mean somebody else, because I don't necessarily know how to do this, but they performed this classification tree analysis, and the three factors out of those factors listed that significantly impacted improvement were the site, race, and behavioral health diagnosis. And that behavioral health diagnosis is whether or not they had a behavioral health diagnosis. So this leads to a million questions. A, is it reliable? I would say not yet. We only have 99 results that fit the model. So we wanted to see if this holds up over time. Race is normally a pretty reliably measured thing, so I would assume that the race information is probably correct. The behavioral health diagnosis information, I would be more curious about that. Is everyone really filling out behavioral health diagnosis information as cleanly and completely as they intend to? my guess, and I'm going to look back on this now that we have this information, is that there are a lot of organizations that aren't including that information. And I'll bet you it drops off when we redo this in a few months. But I don't know. Why would I assume that my assumptions are more accurate than this analysis? So these are the things that we'll see. So it's interesting. It's good food for thought. It adds a lot of questions to the discussion around SBIRT. And my point to you all is that you have the resources available to you in your QI departments, your evaluation departments, universities nearby to do all this work, to compile these dashboards, to do these classification tree analyses. And hopefully this gets you thinking a little bit about what you can do for the large chunk of folks on this webinar who are not yet doing SBIRT but can see their organization doing SBIRT in the future. I think, Sarah, we're going to do some questions now. Is that right? Does someone agree to do questions?
Yep, and we have a couple that have come in here. I don't think we'll have time to ask all of them right now, but any questions that we don't get to in this first session, we'll address at the end of the webinar. So our first question is, does conduct disorder also predict substance use disorders?
Let's see. So I guess I can answer this. So I haven't looked at the data specifically around conduct disorder. The study that I cited earlier, what I placed on the slide was the top 5 predictors. And I think you saw one of them was oppositional defiant disorder, which is sort of similarly situated with conduct disorder. So, my thought about it is it's probably a good bet that conduct disorder is somewhat related to this idea of substance use as well. But I haven't looked at the data about that particular, phraseology of the disorder. So.
Okay, great. Thank you. Now this is our second question. It's from a little bit earlier in the presentation as well. What is the reasoning behind not including alcohol use in these trends?
Oh, well, that was there wasn't a whole lot of reasoning there, other than I sort of assumed coming into this that folks, had some understanding that alcohol use among youth, binge drinking and the like was still, very much a problem, in this country. But I wanted to make sure that, through this presentation that, we had some representation of all the other substances that youth were actually using as well. Like what else shows up on the list in addition to alcohol. So there wasn't, by no means was that anything, trying to downplay the significance of alcohol use within this population. It's just more to make sure that people understood that, the other substances that are being used in, pretty significant proportions, even beyond alcohol.
Okay, great. Thank you. Our next question is, were these findings about tobacco use in addition to marijuana and alcohol use?
So is that, I'm not sure if the data that I presented had the tobacco use in there, but I know for our project we do ask a question about whether folks use tobacco. I don't know if Aaron, if you remember what the data is there on that?
Yeah, and you know what? It's funny because you and I argued about this way back when, where you wanted to ask the question, I didn't, and I remember specifically saying, I just don't think anybody's going to care. And clearly people do care, and that's why they're asking right now. So feather in your cap. But no, we haven't included that in our analyses. And that's another thing that's helpful here during this webinar is that I showed you all the information that we're collecting. I am open to suggestions and requests for how to look at it. So that's something that we should have added to the classification tree. We should have looked at whether or not smoking status led to outcomes, led to improvement. We should have looked at whether smoking status led to people attending treatment. We should look at how all these different factors interlink. And I would say one place that might have some good information about that right now is Behavioral Health and Wellness Program, BHWP, Chad Morris from University of Colorado. I would suspect that he has some information about that, but I don't know for sure. But yeah, that's good feedback, and we should be including it.
Yeah, I definitely agree that Chad Morrison's organization at the University of Colorado, they do a lot of work around tobacco cessation and helping the behavioral health organizations implement tobacco cessation programs, so they may have more information about that. I mean, I think we did on the reports collect some of this data, but it's not included in the analysis right now. But ultimately, we probably can go back and begin adding that as a part of our sort of factorial analysis to see where that kind of shakes out as it relates to this. It could be that folks that are having that also smoke are more resistant to taking the referral, or need multiple brief interventions. But as you said earlier, I think the important thing here is that you are, in addition to implementing the project, you're collecting this data and beginning to look at it. So.
Okay, great. I think we'll just take one more question, and then we'll take the rest of the questions at the end here. Did you learn how the CBO were getting reimbursed for providing SBIRT services and sustainability?
Yeah, so we can talk about this a little bit toward the end if you want, but so really it varies sort of state by state. There are lots of states where many of the codes related specifically to SBIRT were really designed for primary care services. A lot of the agencies in some of the states actually, many of these services were included in their overall rate in terms of screening and assessment and intervention. So they weren't getting necessarily an additional funding stream for it, but through their their current sort of rubric, so to speak, there wasn't an issue with them beginning to add these services on. Some of them, I think, are getting some sort of, rate or benefit, but they have to go through a specific training course or training session within the state that's like approved by the state, and then they can bill, for these particular services. So the states are really, thinking about this very differently in terms of how they're addressing that, and that's part of what we've been working through over the last 2 years, is really looking at, how agencies can, really begin to think about, what the cost benefit is of providing these services. For the most part, I will say that most of the agencies didn't necessarily see this as a next level revenue stream, but they saw this as much more of a way to begin providing increased quality care for the adolescents they were seeing. They really saw a gap in terms of the service delivery and their ability to provide, the sort of positive outcomes they were seeking. And so I think a lot of the work here you see is them really sort of taking the initiative to begin providing these services in order to, provide some better outcomes, for their client population. So it's really kind of a balance there. But looking at the states, it really depends on sort of what state you were in and how they are, processing, these sort of services.
Okay, great. Thank you. We'll take any other questions at the end of today's session. You can feel free to keep submitting them to the questions box.
Okay, and so now I think, with, Aaron's presentation, again, I think is really focused on, the data and having some data, for the project. And, as you all think about implementing SBIRT or these screening, brief intervention, referral services, making sure that you have, some level of data, and you can use that to begin to continually sort of improve the process. Again, I think, as the data sort of demonstrated that Aaron presented, this really was a sea change for a number of these agencies, and we're still, a bit of a work in progress in terms of getting them to, kind of where we want them to be in terms of universal screening and, doing the brief interventions, very consistently, and referrals, length of time between referral, and all those things that are, indicators of high quality sort of service delivery. We're still, working with them in terms of, getting these services in as a routine part, of their practice, and that's really a lot of what the TA has been about and what it will continue to be about. But the data allows us to have some markers, so we can go back and talk to the organization, so we can adjust our technical assistance and really, sort of focus on, how we can, help them improve processes, those kinds of things. So what I want to talk about here with the time we have left is, based on what we've done so far, based on what the data, the feedback we've gotten, really think about what the considerations are, for agencies who are trying to do this or who are thinking about doing this. Really sort of, helping you with, sort of, tips and resources that we've, gleaned from this particular project around a lot of implementation of a lot of these services. So the first thing I would say is you actually, before you undertake any of this, you want to conduct what we call sort of a workflow analysis. Begin thinking about this idea of, how do adolescents or patients in general receive care? What happens when someone calls up and says, I have a child who is, in trouble and they need some assistance. Who do they talk to first? Who do they meet with? How do you, process them through, your particular service array? And once you do that, really want to think about, using a flow chart or something and really get that map down. Many organizations are providing services, and they sort of have essentially procedures around this, but they don't necessarily have any sort of visual representation or sort of have it mapped out. And we encourage folks to take some time to really map it out and then begin to think about, how do I layer in, these additional services around substance use? Where would I put, the screening? Who does the screening? If they need a focused 15-minute intervention around substance use, where would that go? Who's the team member that documents the screening, those sorts of things. So really spend some time and begin sort of mapping out your current state and then looking at what the, to-be or future state would be implementing these services. I think if you approach it that way, you'll really have much, much better success in terms of the outcome of implementation. So, talk about the first sort of elements of this, screening. And, again, as we think about it, this is something that is, rises to the level of, really needing to be universal, particularly in these kinds of settings, that you should ask questions about substance use, alcohol, drugs, the like, and it should be a routine part of the care you provide. Again, we, looked at the data, there's clear connections between substance use and mental health issues, and these things ought to be, there in really sort of a universal format. Now, with this project, again, some of the agencies are implementing this in specific programs. Some of them are doing it agency-wide, but really what we're trying to do, and I think what the data that Aaron, presented, is move them towards some sort of universal screening, whether that's for the program that they said they would participate in the site, in the project, or for the program, for the entire agency. So really thinking about, this is a normal part of your service array. How do you, do that? So then if you're thinking about screening, you want to then, have some conversations. Well, how often do you need to do this? I think for the purposes of our project, I think we were doing it at least 3 or 6 months, I believe, is when they're supposed to have some sort of rescreen, depending on how often you see them. There were some agencies that actually reported to us, that, they see people, I think, more frequently when school was out of session, or when school was in session, as opposed to when school was out of session. So, it's easier for them to screen more frequently at certain points in time, versus others. Some agencies, they just don't see kids quite as much, so you have to go a little bit longer. But the important part is that you have a screening process initially, and then you have some sort of rescreen or follow-up process that allows you to really check on progress, intervene, and again, if necessary. So just thinking about where you want to put that. Do you put it in your clinical assessment at the first interview? Do you do it with the first time they actually see some sort of counselor or therapist? Where do you want to do that? Is it a part of the intake form? Really doing some thinking about your workflow and figure out what makes the most sense for you to implement these questions. The craft and the uncope, they aren't long screens, so there aren't a lot of questions that you're talking about there. So that may have an impact on the type of screen that you're using. How long it is, the length of it, may have some impact as to where you want to put it, in the process. But the important thing here is you find a place where your providers or staff can do it, and it can become a routine part of care for everybody. Brief intervention. All right. So if you're thinking about brief interventions or these kind of focused conversations within sessions around substance use, which is what we really were sort of advocating for, you really want to again think about sort of who conducts it, how often you do the brief interventions, again how you document this, because you want to have some record of this. Again, if it's routine, if substance use is a part and parcel of what you're going to do in terms of asking these questions, you want to have it documented somewhere, within the record, EHR, or the note. How do you, talk to other members of the team about the process if someone else or separate is engaged in this sort of, intervention? How does this get back to the rest of the team? How does this get back to the mental health therapist if it's separated out? Many agencies it's not, but if it is, how do you begin to sort of make sure that the communication loop is closed? And here's some of the considerations. We did a lot of conversation with the agencies. Again, they're predominantly mental health agencies. Some of them had co-occurring disorders counselors, some didn't. Some of them had separate sections of their organization that actually did provide addiction treatment services. Some didn't. So really, it was kind of I won't say a hodgepodge of sort of agencies, but certainly very diverse agencies who participated, and they all had different, kinds of workflows. And you want to do something that's consistent with, the workflow that you have. So, thinking about the availability of time, when can you do this where it makes sense? Staff, you need additional staff, like where do they sort of fit in? How does the intervention integrate into other aspects of counseling? Again, if you think of this and asking about substance use as a routine part of care, maybe you don't want to, have a separate session. Maybe you want the, therapist of record to be able to deliver this sort of, intervention or, the focused conversation around substance use and sort of what's happening there. When can you follow up for future interventions? Is it possible to see them back in a week if you need to follow up further or more quickly because issues are, more serious? Again, what's the comfort level? We'll talk a little bit more about this staffing one a little bit later, but what's the comfort level of the team in terms of providing these services? Are your counselors and therapists skilled in motivational interviewing and really negotiating with the youth and talking to them about some of these issues? Again, that's something you also want to take a look at as you think about who can do these services. Referral. Now this is a more interesting one, and I think as you saw from the data, relative to the number of folks who are being screened, there will probably not be a lot of people who will actually rise to the level of needing a referral to treatment. However, you do have to have, in order to do this and do this effectively, you certainly do need to have, I think a level or maybe a more significant level of policies and procedures in place to make sure that you can have some sort of seamless transition if someone comes in and needs that higher level of treatment. Again, so thinking about sort of what are the availability of resources for treatment. A lot of places across the country, a lot of states across the country have significant issues in terms of availability of treatment agencies for adolescents, particularly if someone is in need of inpatient services. There may not be very many options. What's your agency's relationship with those options? Are some of these things that you can do in-house with your current staff? How do you begin to think about that? But certainly, You want to make sure that you have a plan in place, some knowledge of the available resources that are out there in the community if you need a higher level of care than your agency provides, or if you're like a larger agency that has sort of separate substance use services. When do you make the referral, to the other part of your agency, that kind of thing. You really want to have some things in place. Actually, there's I think a couple of states they actually have a scenario set up where I think they had like another grant or something where they literally would have folks who are providing substance use services come in and do sort of a meet and greet with their providers and just talk to them about the services they provided. So the therapists and the counselors at the mental health organization actually were able to meet with the therapists, intake specialists, and counselors at the addiction treatment site, so they got a sense of who was doing what the services were, and develop the kinds of relationships you need to really make these kinds of seamless, referrals. So if you think about, what you may want to do here, I think that's a big part of that. I think, oftentimes the other thing that I do want to mention is sometimes, based on, the screening and assessment scores, someone may need a higher level of care, and you're well aware of that. Oftentimes the brief intervention may be less about, reducing their use as much as it is about working with them and working through any sort of issues around them taking the referral to treatment. Again, because you want to be able to provide, a level of sort of seamless access and comfort. So sometimes you may have to, work with the client and or their family around sending them to treatment. I think, for this project, we actually had one situation where, a person needed referral to treatment, and it was their grandparent, I guess, who was their guardian, who was much more resistant to that process. So they had to do some work and some discussions with them in order to make them more comfortable with the process of making that referral. I think that person ended up taking the referral and ended up doing, pretty well, in those services. So just thinking about that and making sure you have those protocols in place, to move forward. So here, again, these are just some considerations to think about as you look at this idea of referral to treatment. So again, making sure that you're being very proactive and facilitating, the call to the provider, with the patient. You don't just hand them a number or a sheet of paper and say, hey, call this number, see you in 2 months. As you actually are very much, being proactive about that process. Maybe even doing follow-up reminders, about that. Having conversations, beforehand with the agency that you're referring to about sort of what the relationship is and, what the expectation is about information coming back, to you all, and I'm letting you know that the person, made their appointment, missed their appointment, here's what happened, that kind of thing. So really, again, developing these systems and working with the clients around barriers, whether there's, transportation issues, other sorts of resistance. It's something that you, again, if you want to do this well, you really have to pay attention to. Again, you won't have a lot of folks who will need this level of care, but again, needing a referral to substance use treatment or a higher level of treatment means that these people are in, not in good straits, and you really want to make sure that they actually receive these services, that they get to these services. So again, this is just, some considerations there. Staffing. So this is kind of a big one. I think this is something that we are, continually working with a lot of the agencies involved in the project. This idea of sort of, who should be providing these services, really understanding kind of the roles and responsibilities. Taking a step back and really thinking about this idea of what are the needs. Now that we're beginning to, provide these services, what are the needs related to substance use disorders? Is my staff, actually prepared? Do we have enough knowledge about the disease of addiction, to really provide these kinds of services? Do I need to, have some of my staff trained take a webinar or take some other coursework to get them up to speed. What types of services will, the person provide? Are these sort of just therapy sessions, brief interventions? Are they going to do assessment, intake? What are the actual services? And what provider is best suited for that? I mean, that certainly has a lot to do with who's able to bill and not in different, roles and responsibilities. But certainly you want to, think through that. Is a social worker the best person to deliver some of these, services? Is there someone else, maybe a peer or someone that can do some of the screening services? What are they licensed as? Are they licensed and credentialed? Are they certified as a drug and alcohol counselor? Do they have that skill set? Can they bill for those services? Do they need that skill set? Really having some ideas. It takes some time to think about, what is it, that these particular staff members will need. Certainly there'll be some needs for retraining and other things, which we'll talk about in a second, but really paying attention to that, whether or not your staff have the skill set and whether or not you have to really engage to provide them with any sort of skill, any sort of additional training or hiring others with specific skill sets. Okay, so data consideration. So Aaron, I don't know if you want to say anything about this.
Yeah, so I think I said a lot of it already. I'll try to keep it brief. But for those of you who are embarking on this SBIRT journey and want to start collecting information about your process, start with whatever's readily available to you. If all you have off the bat is the number of people screened, great. Look at that number. And if you want to pop down to the approach with curiosity point here, look at that number and ask questions. Is this really the number of people we've screened? Is this number reliable? And if so, what does it mean to us? Are we happy with the number? Are we not? If we're not happy, what can we do to fix it? So that might keep it simple to start. Start with a couple numbers, put them in front of everyone who's involved with the project, everyone who can affect it at some kind of regular interval, monthly, bi-monthly, quarterly, whatever makes sense for the group. Put these numbers in front of folks and use that curiosity to slowly grow what you're reviewing over time to monitor your process and eventually your outcomes once you've been doing it for a few months, and reward success. So we have this benchmark of screening 90% of everyone who comes through our door, or 100% of everyone who comes through our door. Once we get that, we have a pizza party. We do something exciting to reward the work that went into reviewing the numbers in front of everyone and brainstorming actions to improve those numbers. That's all I've got for that.
All right. So a couple of closing thoughts here. Again, the executive level buy-in is going to be needed if you want to implement these sorts of services. Again, this is really, more of a sea change for most of these organizations. So you really want to have executive buy-in for the initiation of any sort of project related to implementing SBIRT or these sorts of services. Again, to ensure sustainability, you really want to have some written policies and procedures around this. This is one thing that we really noticed as we went through the project, that a lot of agencies had the protocols that we had provided for them initially, but they hadn't layered in more specific policies and procedures internal to the organization. And if you want any sort of activity like this to live on beyond the grant funding or the project funding, or beyond one person's sort of impassioned efforts, you really want to make sure that you have some written policies and procedures in place as to how to do things, what should happen, who to go to in case you need help or assistance. Have that layered into your project. So you really want to have that. Certainly staff are going to need ongoing training and support. Things around youth, what we know about youth and adolescents and brain development and behavior is changing all the time. What we know about substance use and how it affects the brain and their development is also changing all the time. agency priorities, state and federal level priorities are changing. So you really need to understand that, even if you have a good policy and procedure and, things in place, the staff are going to need ongoing training and support. You really want to build that in, whether it is a couple of webinars a year or, something where they can go to particular trainings. You really want to think about the fact that they're going to need refresher courses, other things to really support them as they move forward. So you have to, factor that in if you want to, do this. The other last point is the more routine the service, the more sustainable the practice. So, if you, the more you view this as a part of what you do, the more routine it is, the more you push forward this concept that we ask everybody about substance use. It's something we do. It's a part of our core business. The more routine and sustainable that practice will be. The more it becomes like a special project or something over here or over in the corner, the less likely it is to, be able to be sustained or, really spread to the larger organization if that's a goal. So really think about how you can make this routine, how you can make it seamless, and that'll go a long way in helping you sustain the practice. So with that being said, I will stop here. And these are some resources that we kind of put together just in case, folks wanted to know where they could go for other resources. Certainly, NIDA, the National Institute on Drug Abuse, has a number of different resources for substance use, particularly around teens. Center for Disease Control, CDC, they have lots of data, infographics, and other things around youth and adolescent health in general. A lot of information about alcohol, adolescents, other things. Where Aaron and I both work, the Center of Integrated Health Solutions, housed at the National Council. We actually have an SBIRT-related clearinghouse that's on our website that has screening tools, brief intervention information, referral information, lots of information that's sort of collected from across the country. Certainly the National SBIRT, HTC, the host of this call, have a lot of information similar as well. Definitely a lot of information that you could benefit from as well. If you're looking for, evidence-based practices related to serving youth, certainly SAMHSA's National Registry of Evidence-Based Programs and Practices, NREP, is helpful. The Addiction Technology Transfer Centers in general, which the National SBIRT HTDC is a part of, certainly they have a wealth of other training materials that are available there. NIDA has actually developed a guide which has principles of substance use disorder treatment, a research-based guide of things you may want to do if you're looking into that. And also I put here is actually an infographic from the Hilton Foundation that talks a little bit about, what the early warning signs of, addressing substance use is. There gives you some information there that you might find helpful. Or even if you download the infographic and you want to put it up in your office or something like that, as a way to spur conversation about substance use, that's actually a vehicle as well. Okay, so I'll stop here, and if you have any questions for either of us, feel free to ask. But thank you.
Okay, great. Thank you both. We do have a bunch of questions that have come in. I don't know if we're going to have time to get to all of them, but any questions we don't get to, we'll put into a Word document and send it to today's speakers, and then we'll disseminate those answers to all of the attendees. So our first question is, do you see substance use counselors being hired to do this, or will it be done by mental health counselors?
So it depends. Depends on the state. Depends on sort of the what the sort of billing structure is in some of the states. Some of the states they're able to either bill or they can be reimbursed for these services. Addiction counselors. Certainly, I think it's something to think about because they certainly based on their training and expertise, they have readily available skills and expertise. To be providing these services. Not to say that other mental health professionals or, social workers or the like, don't have it necessarily, It's just, addiction counselors, that's what they're trained to do. It really depends on sort of the state and what happens around billing, but certainly I think that's something you need to take a look at in your state and really think about. I think, addiction counselors will be very much viable to provide that service, sort of a natural fit, assuming they can be reimbursed.
Okay, great, thank you. Our next question is, do you use SBIRT with tobacco?
You can use this in a way with tobacco. I mean, it's, I think there's some variations in terms of what you would do or how you would sort of think through, getting folks to, reduce or cut out, tobacco use, and certainly, other, avenues and mechanisms available, the use of NRT medication and other things. But certainly if the idea is asking about tobacco, if they say, yes, I use, engaging in some sort of, intervention or brief intervention, exploring why they use and, what you can do to sort of stop or cut back, and then referring for more services. Certainly that model or that public health construct can fit around tobacco use as well. So yes, it's not exactly the same, but it's certainly the structure can fit.
Okay, great. So this will be our last question for today, and again, we will share all of the remaining questions with today's speakers and share those answers with you following the webinar. So what is the screening guidance scores for the craft?
So I'm trying to remember. Do you remember right offhand, Aaron, or do you have?
No, I'm scrambling to open it up on my computer right now. We have a craft guidance document and an uncoped guidance document that we can send out to everyone, but I don't have it on hand right in front of me right now.
Yeah, but certainly we developed some guidance around that in terms of, what, the scores meant, those kinds of things. I believe it's on a scale of, was it 2 to 5 or something like that, but certainly we can send that out as one of the follow-up materials for that.
Okay, great. Well, thank you both. I want to thank you for such a great presentation, and I want to thank everyone else for their participation. At this point, I'm going to take the screen back from you, Aaron.
Okay.
And I'm just going to go over some of our continuing education information and evaluation information. Okay, so following today's webinars, you're going to receive a few emails from us. In these emails will be a link to the recording of today's webinar as well as a PDF version of today's slides. And also will be a link to the evaluation and all of the CEU information. Now, our grant evaluators are required and pleased to collect feedback from all event participants. Completion of this evaluation is critical to maintain our funding, and the evaluation should take no more than 2 minutes of your time. Immediately following the evaluation is a request form for a certificate of attendance or a NADAC or PA-CADC CEU. Should you choose to skip the evaluation and proceed directly to the CEU request, just leave all the answers blank on the evaluation. Now, to access your free certificate of attendance, you simply need to log into your MyIRETA profile, where you can download all of your certificates. You can also purchase a free PA-CADC certificate or a NADAC certificate through those purchase links. Once you complete your checkout, your certificates will be available for download in your MyIRETA profile page. Again, we want to thank everyone for their participation today. If you have any additional questions, feel free to email us at info@ireta.org. Okay, great. Thank you so much, Mr. Williams and Mr. Surma. We really appreciate your presentation.
Thank you. Appreciate it.
All right, thank you. Yeah, thank you.